large central airway here with this cartilage, and it's lined by this bronchial type epithelium. And you can see it's diffusely involved. We have these large areas of necrosis, but the rest of it is really just a sea of blue cells. So then when we look down at higher power, we see this diffuse sheets of these cells. They are relatively cohesive, but they're not really forming any structures. I do want you to notice that they look a little bit on the monotonous side. While there's lots of mitotic activity and there's areas of necrosis, they all look very similar to one another. We're not really seeing a ton of pleomorphism and atypia. They're really a little bit on the monotonous portion that should kind of clue you into the diagnosis. So as we look through these areas, we're not seeing any definite glandular or squamous differentiation. But if you move down to here, sorry, just move a little bit quickly, you do see some areas where we go from this really primitive looking cell type to where we're actually forming keratin. So this is what we call this abrupt keratinization, where you go from this really primitive looking cell to kind of this cell that's forming keratin. So that's a real good clue to the diagnosis in this case. So this is actually a nut carcinoma. And so that is a characteristic feature of it. So this is actually a translocation-driven tumor that often occurs in the midline, but not always. Classically occurs in younger males. You can see it within the lung, mediastinum, as well as head and neck. These are typically quite aggressive tumors, and they're characterized by a translocation between NUT and BRD4, which causes an interesting mechanism of tumorigenesis, where this complex between NUT and BRD4 will bind to acetylated histones on the DNA and then recruit P300, which will then put down more acetylation marks on the histones that allow propagation of these complexes between NUT and BRD4 to cover large areas of the chromatin to cause these changes in gene expression that allow it to adopt this really primitive phenotype. Interestingly, if you knock this complex off, that actually causes the cells to abruptly differentiate into squamous cells and die. And people are currently exploring the use of BRD4 inhibitors and other inhibitors to target this. So it's an important diagnosis to make because these patients can have a quite aggressive course, and there is a potential for targeted therapies in the future. The differential for this case would be a more basaloid squamous cell carcinoma or a poorly differentiated adenocarcinoma. These cases can have variable staining for P40 and TTF1. In some cases, they'll co-express both P40 and TTF1. So that's another tip for these. If you see co-expression of those two markers, you may want to consider a nut carcinoma. There's a good immunostain for this that does highlight a nice speckled pattern in the nuclei that is characteristic for it as well.